Thanks, Matt.
Thank you. G'day everyone. Step out and grab a glass of wine if you need throughout. The more enthusiasm, the better. Matt Mcalpine's my name. I'm a rural generalist GP. I work in the ski fields in Victoria, and I came into this week thinking that I had the most appropriate name for a conference at a ski resort, but then I saw that David Mountain is presenting on Thursday, which is absolute bullshit. There's only room for one of us in this town, David. This is Mount Feathertop. That's my favourite mountain in Australia. It's between Falls Creek and Mount Hotham, which are the two mountains that I work at in winter. Thought I might start off by seeing who's gone skiing in Australia. Hands up.
How good's Hotham?
Hotham's all right. Hotham goes all right. So keep your hands up if you've skied in Australia, and keep your hands up if you've been injured skiing in Australia. So, ladies and gentlemen, these are our case study experts. These are the people that have been fucked in the Australian Alps. So if you want to make a friend later on, go and ask them what the heck happened. So I specialise in people who get fucked in the Australian Alps, and I'm going to talk to you about that today. I'll give you a few case studies and a few things that I think are interesting about them. They're not the most gnarly, they're not the most complex, but I think I learnt a lot from them, and hopefully we all do too. Ooh, maybe the wrong one. Do I point it at there? I can use the buttons. So Falls Creek, look at this, love that. So this is an artist's impression of the Australian Alps. So you've got Perisher and Thredbo on the New South Wales side, Falls Creek, Mount Hotham on the Victorian side. And for us at Falls Creek, if you wanted to send someone to our nearest regional centre, that's Albury, that's a couple of hours by road. If you wanted to send someone to Melbourne, that's an hour by helicopter. And if it looks a bit flat on that image, then that's because it is. The Australian Alps leave a lot to be desired. So this is the clinic at Falls Creek. This is on a very nice winter's day. We get about 3 of them a year. The clinic was built by my colleagues who taught me what I do know. They built it allegedly with their bare hands 35 years ago. On the left is the accommodation, so it's got room for 4 people, or 4 people and their 6 guests. It's pretty cramped. And then there's a few ways to get into the building. You can come through the front door, which is for GP patients, so people with sore ears and STIs and wanting the morning after pill. And on the right is the entrance for the ambulance. So they've got an over-snow vehicle. They go to the lodges and look after the people that have had a little bit too much fun and fallen asleep after a night on the MDMA in the snow. And at the back door is where the real action comes in, and that's the ski patrol entrance. So just like all of your respective emergency departments, if you're coming through the front door, you're not that sick. So we have a couple of nurses, a couple of doctors if we're lucky, depending on the time of year. So if it's the weekend or if it's school holidays, and we'll have 2 doctors, 2 nurses, sometimes a radiographer. Most of the rural generalists that work there have their X-ray licence, which is helpful, but great to free your hands up if you've got a photographer in the building. And a couple of paramedics as well. They live on the mountain, and they will go down to Albury when you send the car off the hill and rendezvous halfway in Mount Beauty and come straight back up. So you want to be really judicious about who you send off, because once you say goodbye to your paramedic colleagues, you might not see them again for a few hours. A lot of cafes in Mount Beauty. So this is the view from the accommodation out the back. That's the ski patrol entrance. And on the right is our ventilator, our anaesthetic machine, which I'm told is also the same brand or model that they have in Antarctica, and it's used about as frequently. So these are the clientele that we see. There's 2 types and not many in betweens. You've got the ski bum dirtbags on the left. I identify as a ski bum dirtbag, a well-paid one. This is Mally, who is also a ski bum dirtbag. He came to visit. So these are the 19-year-old lifties that are just really keen to have a good time. They spend all of their money on beers and drugs, and if they get sick, they'll avoid coming in for 3 months until they can go home and their parents pay for their healthcare. And on the right, you've got the big timers, the big dogs, the ones with all the cash. And I've got no shame in charging them as much as it takes to convince them to stop hurting themselves. So The case in point was a chap who munted his clavicle and had to have it fixed by the orthopods in Melbourne, coordinated everything, got him lined up for surgery the next day. He just had to turn up to the Epworth at 7 a.m. fasted. And he said, oh, shoot, does that mean I'm going to have to go down tonight? And I said, oh, yeah, probably. He said, oh, I really don't want to end Jenny and the kids' ski holidays. Do you have a helipad here? And I said, I mean, yeah, sure, but I mean, the weather's pretty good tomorrow, but if you're asking, yeah, we do have a helipad. He said, oh, great, I might just get my helicopter guy to come pick me up. So he literally, for his collarbone, got picked up the next morning at 5:30 or whatever, flown to the rooftop helipad at the Epworth and had his clavicle fixed. So they come in all shapes and sizes. All right, so spot the difference. So on the left, we've got, it might not be clear, so I've labelled it for you. On the left, we've got Rusutsu. 14 metres average snowfall, and on the right you've got Falls Creek, 4 metres of average snowfall. I know where I'd rather be, and that's where we all are. But I think if you're a doctor working at a ski resort, I'd actually rather be in Falls Creek, because if you're skiing in waist-deep powder, you're not actually going that fast. And if you're falling over and eating shit in waist-deep powder, you're actually not going to hurt yourself that much, just your ego. But if you're in 2 centimetres of ice, you're going pretty fast. And if you're eating shit on 2 centimetres of ice, you're going to hit a rock or a tree or a hole or a wallaby, and suddenly you can actually really hurt yourself. So I haven't met any doctors that work in Japan at ski resorts, but I reckon we see some of the gnarliest injuries in the world because the snow's so bad. And here's some of them. So this is 12 months and a kind of an average for all the people that come through the back door. So a lot of wrists, a lot of collies. We do, depending on what's going on, maybe a Beers block or a hematoma block or some ketamine, and pull those back into place, which is really satisfying, because you can, they end up going off to have surgery, but they can stay on the mountain for a couple more days of apres before they go down. Lots of shoulders, lots of dislocations, lots of clavicles, lots of tib, fib, boot top fractures, a Liz Frank there. Some weird and wonderful ones that don't happen on the slopes. So on the bottom left, poor kiddo being carried by mum in a carrier, slipped on the ice and fell on them. On the bottom right, my least favourite things are toboggans. That's a fire hydrant toboggan injury. And I rarely yell at kids' parents, but if I see them tobogganing on a slope and I'm on call, I'll politely but directly say, this is the worst thing I've ever seen. So a couple of cases for us to go through. This was this season just passed at Falls Creek. Ski Patrol radio call comes through saying 18-year-olds skied into a tree, pain in the chest, pain in the abdo, they're breathing shallow, obs are okay, we're giving them some penthrane because they're in a lot of pain. And they arrive, airway's fine, sats are low, give them some oxygen. They've got a pneumothorax on the left side, and hemodynamics are stable. They've clearly had a head injury, but it's not that bad, at least for now. And they tend to generally to touch on the abdomen, but okay. And this is a jacked 18-year-old. I don't know where that fits in the A to E, but they're like fit, well, jacked, looking really good. If I can say that. And primary survey's fine, just needs a bit of fentanyl to get by. It's a busy day. I'm conscious that this is our sickest patient, but just, they're going to be okay. So this is the x-ray. It's probably going to be hard to see from there, but a tiny apical pneumothorax. That's not the pointer, but it's a tiny pneumothorax, a few rib fractures and some contusions there. And I'm more and more reassured, okay, their thorax injury is going to be fine. He was sore in the belly, so there's an intern in the building. I've just got this whiz-bang new ultrasound Bluetooth thing that I'm wanting to show off, and I think maybe I'll chuck it on them just to be sure that there's no free fluid in the belly. But his odds are stable. He's got a little bit of abdo pain. I'm thinking probably this guy's going to go to Albury, a couple of hours on the road. He can have a CT and he can be analgesed and sent home for his tiny pneumothorax. But then chuck the probe on. This isn't my picture, all the other pictures are, but I was too shocked at what I found to press save on my machine. But that's the right upper quadrant view, liver there, kidney there, and in between is a fat sliver of free fluid. And all of his injuries were on the left side, which was initially a bit confusing, but that's the most dependent area of the abdomen. That's where fluid's going to find its way to. And also on his way in, he was all of his injuries on the left, so he was brought in by ski patrol on his right-hand side. So it was all just going to fall to the most dependent area, so that's where he had his fluid. So suddenly our disposition changed and he was getting picked up and sent to Melbourne. And in Melbourne they did a CT of every part of his body, which they love to do. And I wonder how I can make this play. Let's go. Awesome. So everything's happy except for his spleen, which looks like a water balloon that has just been gone splat on the ground. I'll play that again if I can find a way to do that, but I reckon it's that button and that button. Nice. So yeah, like a tomato that's just gone poof. And the reassuring thing for me, and the thing that I think justified the $8,000 ultrasound probe, was that if he'd gone to Albury, he would have lost his spleen. But he got flown to Melbourne, where they did this thing that I'd never heard of, which is angioembolisation. I've never worked in a hospital bigger than Shellharbour, which has about 10 beds in the emergency. And that's a long word with lots of syllables, but apparently that's a way to save the spleen that's bleeding. So they did a great job, and I felt good about myself in that purchase. And this is the other view of the tomato that's gone. That's how to get fucked in the Australian Alps, folks. Alrighty. So the takeaway for me from this was that at every stage the mechanism was the thing that was more concerning than the patient. So ski patrol, the patroller that day happened to be one of our local paramedics, Jono. And on the phone he said, look, he's hit a tree, he's young and healthy, but it's all a bit sus. I saw the tree, I saw the patient, I saw how far he'd gone after he hit the tree, and I reckon that he's not going to be right. This is his shorthand. Turns out paramedics' handwriting is as bad as doctors. The takeaways here is that probable injury, chest injury, abdominal injury. Love the differential list there, that's great. He's lying on his right side, that's why the fluid had all found its way to the right side. He said to me, this guy's going to be really sick. I think he's got chest injuries, I think he's got belly injuries. And when a paramedic looks in the eyes and they've seen people, without their limbs and says, this guy's really sick, I took that serious. The EFAST is what told us that, okay, this is actually more serious than I realised. Down in Melbourne, they clearly found the problem and sorted it out. And that's case one, and that's the first way to get fucked. So case two, Mount Hotham, the mountain over. This was a couple of years ago, but a case that has stuck with me a little bit. So another radio call from ski patrol. So the story that came through was that there's a snowboarder that's unconscious on Snake Gully, which is by far the busiest run on the hill. They're breathing, but they're unconscious. Someone saw them hit their head. We can come to you. It's going to take us about 30 minutes by the time we pack them up, take them down the hill, put them on the chairlift, bring them up to the medical centre. What do you want to do? We can come pick you up and take you down there. There's a few things going on in my mind. This day, beautiful Bluebird Day. It's a Saturday in the school holidays, packed resort. Bluebird Day, a couple of things have happened. One of them was my fault. One thing that happened was on Mount Feathertop, a backcountry group had a major injury. Someone had a compound femur fracture and there was a high ankle rescue going on. So half of ski patrol had gone down to check it out. And our paramedics had left the hill as well to go and sort them out. The second thing that had happened was our registrar, that was the second doctor on the hill, was playing in their soccer grand final and had asked kindly if he could go and play. And I said, yeah, go on, go play, have a good time. So I'd sent my only other doctor off the mountain and I was in the shit. So that was all the things going through my mind. There's patients in the clinic already, none of them are that sick, and I'm thinking, okay, am I going to leave, am I going to stay? So the question was, do I stick around and wait 30 minutes, twiddling my thumbs, getting ready for this person, or do we go down? I think all things considered, if they were going to take 30 minutes to come up, that's a long time. That's enough time for someone to really crash if their airway's not okay from a head injury. So we went down there, got the go bag with one of the nurses and headed down to Snake Gully. This photo is from someone on the chairlift, clearly, and I didn't get this photo for a couple of months, but I met a chap at the backcountry festival that I was guiding on a couple of months later, and he said, oh, you work at the clinic, I saw this gnarly thing going on under the chairlift a couple of months ago. Were you involved in that? And I said, oh, was it Snake Gully? Yeah, sure. So he sent me these photos. So clearly someone was having a nice photo shoot while we were panicking. So it's way busier than that usually. Up the top of the hill, there's a couple of patrollers doing crowd control, telling everyone to go other ways to get down. Some people are clearly ignoring their instructions. The story was such that the bystanders had seen him hit his head. They didn't think it was that impressive. He was a bit dazed. They checked, are you okay? And he said, yeah, I'm fine. All good, just a bit sore. And then he just sat there. When we went through and did a debrief with the ski patrollers, they brought up the footage from one of the webcams that looked down the gully. And we were able to watch the injury. Super underwhelming, just knocked his head a little bit. And then he sat there, and then we had it on fast forward. He was sitting up, and 5 minutes passed. A few people checked on him, are you okay, are you okay, he's fine. And then after 5 minutes, then he falls to the ground, and then scene begins. So it was about 5 minutes between injury and collapse, and then a few minutes before ski patrol there, and then another 10 before we got there on the skidoo. And unfortunately I had to wear a helmet on the back, but that's, I wish the wind was blowing through my hair as we got brought back to the medical centre, but that's us shooting through once we'd stabilised. A very helpful bystander, a medical resident, was doing a jaw thrust when I got there and was able to give a handover, and this is what we found. So low GCS, only responding to pain and localising to pain, but everything else was shut off. Dilated pupil, not reacting on the left side, and tolerating an OPA. There was one vomit on the snow, and we did our best to immobilise his C-spine. And the question that kind of was there is, do we stay or do we go? There's a few reasons to go. The reason to stay was that this guy's got an unstable airway, and I don't want to be on the back of a skidoo with someone with an airway that's compromised. The reasons to go were that this is the busiest run on the hill. There's a chairlift going directly overhead. We're dealing with, drawing up drugs and doing airway stuff in an unfamiliar environment where, it's a slippery slope. You literally can, stuff sliding away, and it's not my familiar environment. It's not my backyard. So that was a reason to go. And also he's cold, and he's getting colder. He's lying on the snow, and that's not going to help at all. So decision was to get the hell out of there. And on the way up, he had another vomit, and that's complicated. You're trying to think of that C-spine. He's locked into this thing. He can't maintain his own airway, so you're turning him to the side and trying your best. It was all a bit of a dog's breakfast. We got up to the clinic, and by this time, maybe 30 or 40 minutes has passed since his head injury, and things are kind of okay. So he's still needing a jaw thrust, but he's starting to spit out the oropharyngeal. His hemodynamics is still stable. His GCS is perking up, but perking up in not a happy way. He's kind of combative and agitated and not really quite right. His pupils are back to normal, which is weird for me. I don't see a huge amount of these sorts of head injuries, and I thought, why is he getting better? This is not what I expected, but I was kind of relieved. And then I was chatting to his buddies that were with him, and they said, yeah, I'm not surprised he's unwell, because we told him to not go skiing today. He fell yesterday and hit his head, and he was concussed, and he thought, oh yeah, I don't want to miss out on skiing, so I probably should go and hire a helmet for tomorrow. So he wasn't wearing his helmet yesterday, hit his head, out there today, hit his head again, and now he's unconscious. So that was useful information that we'll come back to later. So a few questions for me to answer in this moment is, do we send him to Wangaratta, which is our nearest place? It's 2 hours by road. By this time, the ambulance had come back from their high angle rescue on Feathertop, which is this mountain here. Hotham's over this part of the off screen. So they'd come back. We had the opportunity to send by road, and based on this, I don't think so. Like, is he going to be safe? Is he combative in the back of the ambulance? Is he someone that's going to be going to crash on the way there? So let's not. And then the next question is, do we tube this guy or do we chill and wait for HEMS? HEMS are 45 minutes away, and I haven't done an intubation 18 months. This is not my bread and butter. I don't really like the idea, but I'm ready if I have to. So he's getting combative. He has a bradycardic episode, which we give atropine for, and it resolves, but I'm losing control, and I don't like what's going on. I don't know if I can wait 45 minutes for HEMS to get there and save the day. So This is kind of a halo for me, and that's a term that is talking about high acuity procedures that are low occurrence. So there's something that you might need to do, and when you do need to do it, it's going to be pretty gnarly and pretty important that you get it right. But you don't do them all the time. And I think Tim was talking earlier on about sternotomies, and there might be people in the ICU where for them it's not a halo procedure because they might do one a week or one every few weeks. But for me, doing an intubation is a halo procedure. I don't do many of them, but I'm working in a setting where that's kind of something that needs to happen. So it's a relative term. For me, intubation is a halo procedure, and usually if I'm going to do a procedure like that, the first question is, can I justify it? Is this something that this person needs? And in this case, yes, they did need to be intubated so that they could be flown, so that they could be stabilised, so that they could get to Melbourne safely. Certainly you didn't want them to be in the back of a helicopter while they were crashing without a tube. And then the next question that was even more relevant for me in this case was, can I justify not intervening? And that's the one that got me over the line, because I didn't want to. I don't want to do something that I'm not confident in at least doing regularly. But this guy, I was losing control of the situation. He's bradycardic, he's combative. We're going to have to sedate him in other ways. And if we are going to go ahead with an intubation, it has to be in a controlled setting. So the decision kind of made itself. And this is my love letter to the coroner, just in case things didn't work out. They're the drugs that I had, when I did anaesthetics 18 months prior. This is the stuff that I was saying, okay, when I need to do this in real life, when I'm in the country, when I'm in a situation that's falling apart, these are the drugs that I'll use. Maybe they're not the best drugs in head injury, but the ones that I was familiar with. That's the process that we went through. And it all worked out. Fortunately, this guy was 24 and also healthy, not as jacked, but also quite healthy, and had a good view. So that all worked out. And a few things to talk about. So he got down to RMH and had his CT. They do a lot of CTs down there apparently. And he had a subdural on the left-hand side with a midline shift, and ended up getting extubated the next day. And besides a concussion, he did just fine. And the takeaways for me, I guess there's a couple. This in 2010 was described this second impact syndrome, where you have a head injury and then you have another head injury, and the second head injury is the one that causes harm. And I've spent a lot of time telling patients that this is why you can't go back to contact sports for another couple of weeks, because it's a second head injury that does really poorly. So these are images on the left. Two images are from that study. This is a typical subdural on the far left. So you've got maybe I will get the pointer for this. So you've got your subdural hematoma, tiny little thin line there. You've got the left hemisphere and the right hemisphere, and they're about the same size. Maybe a small bit of reduction in the left hemisphere B from the volume of the subdural hematoma. This is what they were seeing when they were CTing these second impact patients, and a lot of them were having quite catastrophic outcomes because, yes, there's the thin subdural hematoma, but the hemisphere that's affected is larger than the other hemisphere, despite being intruded upon by the volume of the subdural hematoma. So they were seeing that the affected hemisphere had this, cerebral edema and was taking up space already, and then the second head injury was taking up even more space with the subdural, and then that equated to badness. And looking at this guy's CTs, he's got some of those features. So he's got this really thin subdural hematoma on the left side. He's got the hemisphere that's unaffected has been affected by the midline shift. It's moved across, but the hemisphere that is affected is much larger, despite it being intruded upon by the subdural. So I think this chap had, to some degree, this second impact syndrome, where the day before he'd hit his head, he'd got this edema on the affected hemisphere. And then the second head injury, even though it was underwhelming, certainly looking at the footage from the snow cam, it was not a major head injury, but that's the one that meant that he did poorly. And then I'll switch back to the other. Look at that. And then the other thing that I took away personally from this is this concept of clinical courage that This was described and heard about last year and are really related to the rural generalists. We work in the middle of nowhere, often single doctor towns, often a community of 1,000, 2,000, 3,000 people, and we're expected to look after whatever comes through the door. It's an unconscious kid, or it's an acute asthma, it's a status epilepticus, but we might only see them once every now and then. But I do feel like, even though this term was used to describe rural generalism, I think it's applicable to most of us in our work in emergency care, where we're nursing in our emergency departments, or we're out in the field as paramedics, and these I think apply to most of us. So we see whoever comes in, doesn't matter who or what age or what their problem is. There's always going to be uncertainty. Because of that uncertainty, we're constantly preparing. We're aware of the limitations of our resources, so based on the context, we'll be quite creative in utilising the resources that are available to us. We're always seeking to know where the limit is for our clinical skills and our cognitive capacity. And then when something does need to be done, often the hurdle isn't that we know how to do it, it's deciding to do it. And for me, that's the main takeaway of this, is that I need to know how to do the things that I might one day need to do, but am I going to be able to overcome that hurdle? And that's where this kind of clinical courage comes in. And what I found the next day when I was debriefing with the nurses that were up there with me was all of them were working in intensive care departments in Melbourne. That was their bread and butter. So we were debriefing and they were excited to talk about the clinical stuff. They're like, oh, why'd you use ketamine? Like, they had a head injury, blah, blah, blah. And I was like on the verge of tears. I'm like, yesterday I did something that I really hoped to never do. And for me, it was them being able to reassure me and say, hey, it all went well, you managed the team well, and gave that collegial support to me to turn up the next day and keep working. So I think that we all do that in our own way, in our own workplaces. And that for me, that term gives me a lot of confidence going back out there to do this stuff again. And then the final case before some questions is real brief. This is a 52-year-old lady, and I'm going to quote her here. She was hit by a fucking snowboarder. So she's come in on the patrol sled, and her arms like this. And usually, if you've dislocated or seen many dislocation shoulders, they're pretty happy to keep it close to their body. But she's out. And no one, and imagine the poor patroller's trying to put her on the back of a skidoo on a sled, and her arm's out like this, so they've like padded everything and given her 2 penthranes, and there's nothing I can do to get her to adduct that shoulder. It's just out. It's just, so clearly it's dislocated and deformed, but we're all very excited to see what the x-ray showed. And this is why it's stuck out there, because she's got this fat, greater tuberosity. I mean, you could call it an avulsion, but it's just a floating bit of shrapnel, really. It's a cooked shoulder, and I'm looking at that thinking, okay, we're 2 hours away from the nearest orthopaedic surgeon, but she's in agony. She can't adduct her shoulder. We're in a bit of trouble here. So we set up to do, a procedural sedation and try to put her as much to sleep as possible without needing to have an anaesthetist. And so she has some midazolam, she has a fuck ton of ketamine, and then the situation, it was laughable in hindsight, because I'm there pulling every technique that I've ever seen or heard about and trying everything, and her 2 late teenage daughters in the background thinking it's hilarious that her mum's on ketamine, and then her husband's at the end of the bed next to the nurse who's scribing, and then I'm pulling as hard as I possibly can. I'm fighting and wrestling with this shark of a shoulder, and I'm pulling traction, and finally it clunks, and I go, fuck yeah! And then the husband turns to the scribe and says, did you get that? And we got it back in, and it was all well and good, and thank you for listening. I am spending the last 3 months of the year in Nepal, and hopefully next year you can have me back to talk about how to get fucked in the Himalayas.
Thank you very much, Matt, and we'll absolutely have you back. We've got a question from Peter here.
In the second case that you had, did he have a helmet the second day?
Yeah. So he'd hired one. Yeah.
One of the other questions that came through was, in your go bag, do you have the gear to be able to do RSI out?
Yeah. We took it down, and I guess the goal is to never need to use it. but there might be a circumstance like you might be taken out to someone out of the resort, you know, on another mountain. So you want to have it handy, but you don't want to use it. Someone in the room, Russell, I'll out him, has done a resus on the same part of the mountain and did end up needing to do the full ALS, the full kit and caboodle. So sometimes you might need to do it, but the goal is to not need it, but you take it.
Nice, and I guess the follow up from that one was, do you do any things with the paramedics to sort of, I guess, practice that?
Yeah, we try to, but there's a huge turnover of staff. So most of the medics are coming through, they do a week here and there. The paramedics are a bit more reliable, but they might spend 10 days and then go off and come back. But when possible, we do, yeah.
Nice, and my favourite question and the last one that we had for the night was just how Jack was the 18-year-old. And do you have any photos you can share? Well, whoever asked that question, feel free to have a chat to Matt later, but probably a good time to call it, I reckon. Matt, if this doesn't work out for you, the whole medical thing, I reckon stand-up comedy's probably next. So let's hear it for Matt. Thanks, Matt.